Okay, so diverticulosis, non-inflamed outpouching. It's like a little, you see the little outpouches that right there? They kind of form out from the intestines, but they're not inflamed. And they're typically lots of them, multiple, and the patient doesn't have any symptoms because they're just little pouches, they're not inflamed, they're not infected at this point. A lot of times patients don't know they have them. I'm going to go to the this form right here. So who gets them? They tend to be older adults. Western culture. It's interesting that like in Africa, where they have very high fiber diets, this disease doesn't exist whatsoever. But here in our Western culture, where our diets maybe aren't so great, then we see it more often. Especially because we tend to have low fiber, high carb diets. And we're also an obese country, unfortunately. Also, decreased activity. And it causes this outpouching of the mucosa. Typically, there's multiple little outpouchings. And if they're non-inflamed, they don't have symptoms. This is diverticulosis. So what's happening that we develop like a diverticulitis? So that smooth muscle of the colon wall thickens. I did a lot of work for you on this one. You guys don't even have to write this stuff. And basically the stool slows transit. So there's not a lot of fiber. Fiber is what gets things moving, right? And that's why we don't want to have a lot of fiber or residue in IBD because it's going to get things going. But normally we want that. So this lack of fiber slows the stool down. More water is then reabsorbed because remember it's in the large intestine. It's getting all that water is getting reabsorbed. So the stool is becoming kind of harder, thicker. It increases the intraluminal, so inside the lumen, inside the intestine pressure. And because it's got that pressure, it causes those little outpouchings. Now remember, you've got this hard stool because fluid's being reabsorbed and it's retaining the stool, which has bacteria in it, right? Because in the large intestine, that's where bacterial digestion is happening. And you've got these outpouches that now have stool and bacteria in them. And inflammation and abscesses can occur. And that's what leads to diverticulitis, or inflammation or infection of that diverticulum. So again, when they have diverticulum, they don't necessarily know that they have it.
So these people have hard stroke, you said?
Yeah, because everything kind of gets slowed down. They have that slow transit time. And because it's not moving through the bowels the way it should, you know, we want things at a specific time. It moves too fast, it's liquidy. It moves too slow, it gets hard. So because of this lack of diet, fiber in the diet, things kind of slow down. Stool sits in the colon longer than it should. Water gets reabsorbed. The pressure inside the colon gets higher. It causes these little outpouches. And now they have no symptoms until the outpouches get infected because the stool and the bacteria in the colon get those little outpouches infected. And they develop the inflammation in the abscess. So again, the majority of patients don't have any symptoms. However, there's a small percentage, 15 progressed to the acute diverticulitis. So no symptoms, but they do get left lower quadrant pain if they're symptomatic. And this is diverticulitis. What do you think of when you think of itis? Inflammation, infection, right? So they're going to get fever, leukocytosis. So on a CBC, you're going to see a high white count. You might feel a palpable abdominal mass because stool's getting retained. It's getting, the little pouch you can sometimes feel. There's change in the bowel habits. Again, things are kind of slow, not moving, harder stools. They might be straining to go. And oftentimes their pain is relieved by gas or bowel movement because it decreases that intraluminal pressure. So if you can see, like right here, let me see. You see all these little outpouches right there? Those are the diverticulum that are kind of outpouching out. So when we talk about complications, it's very similar to other things that we've talked about. They can perf if those little outpouches become so inflamed and infected that they burst open. They can develop the peritonitis because, again, you have bowel leaking into that peritoneal cavity. Abscesses can form. They can get sick, which is, again, why, like your patient, Bree, probably had a bad case, maybe had a perf or was about to, so they made the ileostomy to let the bowel rest so that they weren't putting any more pressure on the diverticulum. They can develop fistulas, those little tracts to other areas. They can bowel obstruction from those hard stools. They can't pass because everything's kind of moving slow. They have this increased intraluminal pressure. And they get the hematochezia, which is the bloody stools, the bright red stools.
What's it say, bleeding?
Bleeding. They get like bloody stools. Typically, unlike with like IBD, they're typically maroon color.
So diverticulosis is just when it's not inflamed and then it progresses to diverticulitis.
Mm-hmm. So say it again, I'm sorry.
Diverticulosis.
Yes.
It's just like a pouch.
Mm-hmm. And you could have it, I could have it. After I ate Pringles last night for dinner, I probably have it.
What is there something that causes it to go to diverticulitis?
This whole process that we talked about.
Okay.
Yeah. This part right here.
15%.
Yeah. So a small percentage, because of the lack of fiber, because things aren't moving the way they should, stool kind of slows down, fluid gets reabsorbed, you get hard stools. With those hard stools that aren't moving, the pressure inside the bowel increases. So it's that pressure that causes those outpouchings, that causes those sacs. Sometimes with the retained stool that has bacteria, it can cause an infection, which is what causes the diverticulitis, the itis part. So the pressure causes the sacs, the retained stool of bacteria causes the infection.
Okay.
And then if they develop some symptoms with the infection, a lot of times, especially older or elderly, don't have anything, like they won't have a fever, you might not see leukocytosis, but they'll complain of some vague abdominal pain, they might be constipated, they might say, oh, my belly hurt, and then I passed gas and I felt better, so they think it's just gas pain, but it's really like diverticulitis. But a small percentage progress and get a significant form where these outpouchings that are infected actually perf or get, they develop a peritonitis or they bleed or they develop a fistula. So how are we going to diagnose it? We can develop with CT with contrast. CBC, because if they're hemorrhaging, they're bleeding, we're going to see the hemoglobin hematocrit drop. UA, if there's any fistulas that form. We want to see if there's any blood. And then we don't want to do this during an acute phase, but after the acute phase is done, then we can do a barium enema. Remember, they already have high pressure inside the lumen. So if we then stick contrast up their bottom, what do you think? We're going to just increase that pressure even more, put them at higher risk for perforation. So we don't want to do this during an acute phase. But when they're healthy and they're not actively having symptoms, we can do the enema or do a colonoscopy. So interventions, high fiber diet. So unlike IBD, we want these patients to have high fiber. Fruits, vegetables. We want to decrease red meat. That's shown to harder to digest, slows down the GI tract. No, and nothing like popcorn, nuts, seeds, anything that can get stuck in those diverticula. Remember their little out pouches? So if you have things like seeds or nuts, they can then get stuck inside a pouch, and then that is what gets infected and causes the symptoms.
I guess I was speaking to one of my patients, and they said that the doctor told them that was just like a myth, that they didn't know for sure if the seeds cause it. So is that just something they think can cause it? And to stay away from them?
It's confusing because popcorn is high fiber and yet don't use high fiber.
No, because the kernels can get stuck, is what they're concerned about.
So just like leafy and fruity stuff.
Yes. I mean, popcorn, it's not really what we're, like, if I said high fiber, I'm not going to be like, go eat a lot of popcorn. That's probably not the healthiest high fiber diet thing you could eat. It does taste delicious. I will agree with you. They take laxatives to help, again, because we don't want that slow transit time. We don't want stool just sitting in there, increasing the pressure. So we oftentimes give laxatives to kind of smooth the stool and let things go smoothly. Stool softeners. Again, we don't want that hard retained stool. And educating the patients on this, that this is not just something that we do just during a time of, disease or during an acute phase. This is something we want to do frequently to help prevent symptoms. We treat pain or spasms with Donatel or Bentyl. Lots of fluids. Again, they're retaining that stool, right? More fluid is being absorbed, so we need to increase the amount of fluids they get so that they keep those stools nice and soft so that they can pass them. And it helps increase transit time. Physical activity, we know that gets things going. On a totally random note, I wonder if it will be here. it's not in here. I found the funniest picture this morning. It's totally random off topic, but it's about physical activity. No straining. So we don't want to, anything, again, they already have high intraluminal pressure. So we don't want to do anything that's going to increase that pressure, because the more pressure we have, the more outpouchings we're going to get, and the more chances that we're going to kind of perf those outpouchings or break them open because of the high pressure in the belly. So we don't want them to strain when they're going to the bathroom. That's why we do fluids. That's why we give stool softeners. That's why we do laxatives. We don't want them bending over a whole lot, vomiting. So if they are feeling nauseous, give them antiemetics. We don't want them lifting. Even tight clothing will increase the intra-abdominal pressure.
The pressure we can palpate the abdomen, like it would be hard, or
Yeah, it would be more, I don't want to say hard, because that's like sick if it's hard, but it will be firmer. It's not going to be all nice and soft and squishy.
Low, not like upper gastric, but lower.
Yes, lower. And then educate small meals for them. We don't want them to eat these giant meals that's going to require the bowel to work a long time to digest. If they're having an acute attack, so it's that 15% that's all inflamed and sick, we want bowel rest for these patients. Keep them NPO, we start IV fluids, and we want to help decrease the inflammation or infection. So they often get put on antibiotics, and sometimes their surgery is required. Either to give the bowel rest, like create a ileostomy or colostomy that's going to let the bowel rest. But the big thing with these patients is teaching prevention. Once we know that they have it, all these things that we talked about, like no straining, the stool softeners, the increased fluids, we want to educate our patients that this is something they need to incorporate in their daily lives so that we prevent these acute attacks. We don't want them to get to the point where we have to hospitalize them, keep them NPO, put them on IV fluids. Is everybody good if I move on?
What's the mental and abdominal? Is that yoga?
They help prevent spasms
So they're
for pain and spasm. All right, so we're going to talk about the urinary system real quick. We're going to talk about stones. So you have kidney, right here. Then right here, it's kind of, I forgot to draw these in, sorry. This little like junction right there, that's the pelvis. Right there. And then where the pelvis meets the ureter is the UPJ. Utero-pelvic junction. So kidneys produce the urine. They go right and left, go down the ureter on each side to the bladder, which stores urine, then to the urethra to excrete the urine. So kidneys help remove all the waste from our body and help us maintain our fluid electrolyte balance. Oh, I did write it. Oops. There you go. So we're going to talk about urolithiasis and nephrolithiasis, which is stone formation. So stones anywhere in the urinary system. Urolithiasis is like ureters, bladder, urethra. Nephrolithiasis is kidney stones in the kidney. So just understanding uro means urinary, nephro means kidney, and lithiasis is just stone formation, and it just tells you where the stone is. We're going to kind of talk about stones in general. I'm not going to really differentiate between. Very common. Who gets it? 20 to 55-year-olds? Men. White men. Very common in the southeast and southwest, and that's basically because we have a hot, humid environment. Summer months, again, because of the dehydration. And these are all factors that increase the chance of developing stones. Family history. And diet is a big influence. If they have a diet that's low in fluids, high in tea or fruit juice, high in calcium or oxalate, or high in protein, they're at increased risk for developing stones. High in calcium, oxalate, or high in protein. So why do stones develop? Basically, when you have low fluids, or your pH is too high or too low, then the crystals precipitate, so they kind of clump together. And when the crystals in your urine clump together, it causes the stone formation. So if you're well hydrated and you're able to like kind of flush your system per se, those stones can't develop. But anything that makes the pH too high, the pH too low, or you're dehydrated, increases the chance for those crystals to kind of form together. So things that make your pH high is calcium and oxalate.
What's oxalate?
It's things found in like, I'm blanking right now. I'll put it on my list of things to look up at break. No, acidic is what lowers your pH. Uric acid, cysteine.
Is it in like sodas?
I don't know, to tell you the truth. I'll look it up. I don't want to lie to you. I'm not going to just make it up, but I'll have to look it up, to tell you the truth. Stones can also be formed because of obstruction, urinary stasis. Gout is related to it. And infection.
It's oxalates and spinach, beets, rhubarb.
There you go.
Stay away from
To answer your question, oxalate is in spinach and beets and rhubarb.
and extremes in almonds and cashews and peanuts.
Oh my God, I'm screwed. Almonds. It's in chocolate.
Soy, brown rice, wheat bran.
Look at you guys all have access. You know better than me. And it's just an overabundance. You have to kind of be at risk for it. Like you have to have the body type that kind of. And again, it's more common in middle-aged white men. They're very common.
We're good.
Yeah, we're good. Sorry, Reed. You're screwed.
Yeah.
The acidic stuff is like your sodas, your teas, your juices. That I got. All right. So pain. Now, the interesting thing with pain, when you talk about stones, is that the pain is where the stone is. So if they're having kidney pain, they're having renal colic, that the stone's probably in the kidney. If they're having suprapubic pain, then the stone is probably in the urethra or in the bladder. So the pain kind of follows where the stone is, because it's going to spasm, because urine can't pass the point of the stone, or it has a hard time passing, and the stone causes spasms. So wherever the stone is, that's where the pain is. It kind of follows it around. They get blood in the urine. It can be microscopic, or it can be gross hematuria, where you can see it, and that just depends on that stone. Remember, it's a bunch of crystals that have kind of clumped together, and as it's going through the urinary system, it's irritating the little tubes and causing blood. It can cause nausea and vomiting. They can have an inflammatory response, develop fever. And depending on how bad the stone is, how big it is, how much blockage it's causing, they can even develop like symptoms like shock, cool, clammy skin, and they, like we said, can have difficulty passing urine, depending on how big the stone is. And their pain is severe. It's not like, oh, my tummy hurts. Like, they are bent over screaming in pain, because it causes really bad spasms. So how are we going to diagnose these patients? Obviously by the clinical manifestations, but also UA. UA is going to show us in a culture, UA in culture, it's going to show us if there's crystals in the urine. It's going to show us any hematuria. Like, let's say the hematuria is microscopic and we can't see when they pee that there's blood, but a UA will show blood in it. And that should be red blood cells, not CBC, RBC. An IDP, which is an IV pyelogram. It's when they insert contrast and they can see the stones. They can see the whole urinary system, see if there's blockage.
They insert contrast in an IV.
Ultrasound. They can do a renal ultrasound. They can do a bladder ultrasound. Anywhere to see, if they're retaining fluid, to try to see the stone. They can do a cystoscopy, which is basically where they go up the urethra and look into the bladder. Look into the urethra, look into the bladder. Think of it like an endoscope or the other end. Yeah, colonoscopy or endoscopy, but a cystoscopy is right up the urethra, to look up the urethra and the bladder.
Again, sorry, Reed.
Thank you.
And then BUN and creatinine tells us kidney function.
Should they be high?
If the kidneys aren't functioning, like if there's a stone in there, it's causing irritation.
Citrus is drinking beer helps.
I haven't heard that.
Helps with the pain.
I was gonna say, it might make you just kind of forget the pain, but
It makes you go, and
Yeah,
then
it makes
pass
you
it
pee
faster,
more.
I guess.
well, I would not recommend that as a nursing intervention. You will probably not be tested on that. There are lots of therapies that work that have no explanation, so I never say never, but I am not recommending that as your teacher.
They say drink a lot of stuff that's acidic, like cranberry juice.
Yeah, cranberry juice.
Lemonade. And avoid like the sports drinks because they have so much potassium and phosphorus and sodium in them. And some form stool or something.
Well, first thing you're gonna do is treat their pain. They hurt. They hurt bad. So we typically treat with narcotics. They get IV morphine. They get high pain meds. They hurt. We're going to treat the infection or obstruction. So we'll talk about, in just a second, I'll show you some different ways that they go via cystoscopy or lithotripsy. So if the stone is obstructing, and again, we're going to talk about it, we want to get rid of that obstruction because that's what's causing a lot of the symptoms. If they develop an infection because they can't pass the urine and the urine sits there and it gets infected, we treat with appropriate antibiotics. Again, we're going to educate prevention. It's always our goal with nursing is to prevent them from having an acute disease process or to have symptoms flare up. So we're going to educate them about diet, like avoiding like high amounts of teas and sodas, or increasing their fluids so that they don't get dehydrated, whether that's through typically water or beer. Just increase your fluids. Certain drugs can cause stone formation. So it's important for patients to understand what could cause the stone and how we're going to prevent it. A lot of times they're sent home they don't get hospitalized unless the stone is causing a severe obstruction or unless their pain is totally uncontrollable. Typically we send them home, they're on like a narcotic at home, and they're told to strain their own urine, and it's a super fun process for them, but they're waiting for the stone to basically catch the stone, so the stone to pass. So what it's typically done in a 24-hour period. They are told once they're going to start, they void and they get rid of that first void. Once they get rid of that first void, then they're going to collect everything that they pee for the next 24 hours. So they have a hat at home, they have jugs of pee sitting by their toilet, it's super fun. Or the best is that oftentimes it has to be refrigerated. So you tell these patients, like, here's your jug of pee, and then their pee is sitting in their, like, fridge with next to their, like, ham for dinner. And patients don't want to do this, but it's important to educate them about exactly how to do it, because if they don't do it right, you've wasted the time. You're not going to get an accurate study. And then they typically have to return it to a collection agency with it all labeled correctly, with the right room temperature and all that, or coolness or whatever. So they void the first urine, they collect everything thereafter, and they keep it per the lab's instructions. And again, it's important, especially when you're collecting samples, to know the patient's diet and what medications they are on, because that's going to affect the results of the urine sample. And then prevention is our primary goal. Again, we want to make sure that they don't have stone formation occur, or that it's minimal and we minimize the symptoms. So we talked about obstruction. When are there indications for stone removal? So one, the stone is too large to pass. We can't send them home to strain their urine to collect it. The stone is associated with an infection. It's caused a blockage and infection. It's that pain is too intense. Like I said, these patients can be in severe pain, doubled over, can't walk, or they just can't treat it medically. Or if the patient only has one kidney, a lot of times we'll go ahead and remove it because we don't want that stone to damage the one kidney they have left. So there's a really fun picture. So the cystoscopy, you can see that they insert the tube through the urethra and directly into the bladder. How do you like that visual reading, Chris? Yeah. Basically, they can, at that point, they can crush the stone and then remove it, or irrigate the bladder to remove the small pieces. If the cystoscopy is not going to be enough, they can do a uteroscopy, where they go through the urethra to the bladder and up the ureters. And it can only do like the lower 2/3. It can't get all the way up the ureters. If that is not where the stone is, if the stone's higher, they can do a percutaneous nephrolithotomy. And that's where they go through the skin to get to the stone. So if they need to get up to the like upper 1/3 of the ureters or to the kidneys, they actually go through the skin percutaneous and go in there to get the stone. And again, the goal is to break the stone up so that it's smaller and they can pass it, and then irrigate, kind of flush them out. And then they also do lithotripsy, and we talked about that briefly, where they use the ultrasonic sound waves and they break up the stones into small fragments. And so one of the students was talking with me that does this, and they said they do it with adults. I only work with peds, and if a child is large, we don't do it because we were always instructed that the fat tissue would help, would absorb the sound waves and they wouldn't be able to break up the stone. But I'm being told they do it on all shapes and sizes in adults. So I could have told you totally wrong on that. I apologize. But basically, understand with lithotripsy, the idea is that they send out these sound waves. So it's not a cystoscopy, it's non-invasive. It is painful because think of it, there's this sound wave going in and just kind of breaking everything up. They don't irrigate like a cystoscopy, but it breaks up the stone so that they can pass it. So surgery is indicated for a large stone or pain. Different ones: cystoscopy, uteroscopy, the percutaneous, nephrolithotomy, and the lithotripsy. A lot of times with these patients, it's really important to monitor urine output. Anytime they have any kind of procedure, you really need to monitor urine output. They can get gross hematuria from this. They can develop clots. You know, you're in this urinary system manipulating a lot. You're shoving things up, you're poking things through, you're irritating it. So monitoring that they have urine output. Is it bloody? Are there clots? Monitoring vital signs. Monitoring their pain or any signs of infection. A lot of times if there is a lot of hematuria, they get what's called continuous bladder irrigation, the CBI. And that's where they insert like a Foley catheter and they have the normal saline, and it's basically being inserted through the catheter into the bladder so that it's just continuously irrigating so that clots don't form and cause any kind of obstruction. So again, monitoring urine output is really important for these patients because if they do develop any clots and it causes a blockage, we want to find it sooner versus later.
Don't put in your ureteral stents to see if they can get the stone out.
Mm-hmm.
Keep the ureters open so they can pass.
Yeah. All right. Does anyone have any questions about that? Yes, no, maybe so? Okay. I don't know who these people are. They're just, but they're cute, I guess. The end.